All right, good evening and welcome everyone. You look like an awesome looking audience here tonight. 25 years ago, I founded Pure Romance with a dream that someday I would be part of a future where empowered women were comfortable enough with their sexuality, not only to ask questions, but demand answers about their sexual health. And everyone here knows that sexual health is not a dirty word. There you go. Thank you. As Pure Romance grew, the sexual health questions posed to me became more and more complex. And it became very clear that we needed more resources to turn to. That's why I started the Patty Brisben Foundation for Women's Sexual Health. To date, we have raised over $4 million for research and education. You see, this evening may not be about you right now, but what you're hearing tonight may be meant for someone else. It could be about your mother, your sister, your partner, your husband, your best friend, or even your future self. This past June, the foundation launched a new initiative, a speaker series called #SexualHealthMatters. We have more than doubled in our attendance from the first education night. And you know what? That shows me that it's needed. Tonight, we continue with the next installment, focusing on sexual health and the gender gap. Women experience the gender gap every single day. There are not enough women in the boardrooms, and when it comes to money, let me tell you something. They're still only making 80 cents on the dollar compared to men. And that's not the only gender gap. There's also a gender gap when it comes to sexual health. The FDA has approved drugs for men for a long time now, but only has 2 for women. Why is that? Why aren't these medications being used? Why aren't gynecologists talking about them? Why does our insurance cover these differently? Questions like this are why it's time for this conversation, and the time is now. After all, the sexual experience of men and women can be very different. There's a gender gap in the bedroom. Why do we experience orgasms differently? What about our libidos? What resources are available for men? Sexual health issues. We need a better understanding of ourselves and men. Only with communication and education can we bridge this sexual health gap. I'm looking forward to this conversation tonight. I'm so excited to introduce tonight's group of sexual health experts. Aren't they pretty? Let's start with Dr. Kathleen Novicki. She's a pelvic floor physical therapist with the Center of Pelvic Floor and Core Rehabilitation at Oxford Physical Therapy. Say that with a mouthful. At the end, Dr. Somi Javaid, OB/GYN, sexual medicine and menopause expert of Dr. Somi Javaid, MD and Associates. Dr. Courtney Plattner, UC Health General Urology, focused on men's health and infertility. And last but not least, Laura Pressley, sex therapist at Emma Schmidt Associates, Sex and Relationship Therapy. I just want you to know I'm very thankful and grateful to have you here sharing with us tonight. So if the night gets really crazy and there's a lot of questions, I want to make sure I have my thank yous.
Thank you.
All right, let's get started. We're going to start here with Dr. Kathleen Novicki. Dr. Kathleen, from your professional perspective, what have you seen to be the most common difficulty or challenge that couples face when one partner suffers from painful sex?
From a physical therapy perspective, I would say the most common challenge is that pelvic pain is often not seen. If your partner experiences knee pain, you usually can tell that they're in pain. They're limping, they can't get up and down off the stairs. But pelvic pain, oftentimes you can't tell by looking at them that they're in pain. If your partner goes to the doctor and they have knee pain, oftentimes they'll come home with a diagnosis that you all can understand, and you already know what steps are needed to recover from that pain. With pelvic pain, it's often a more complex diagnosis, so there's a lot more misunderstanding and uncertainty, and especially in not knowing what the steps are for recovery. It's very, very important that there's open communication between the partners so that they understand that there's pain even though it's not easily seen.
Okay, so we kind of touched on pelvic pain. What about if this was a male? How does a female adjust to the male's pain?
Obviously, men and women have different anatomy. In terms of the pelvic floor muscles, which is what the physical therapist often is the focus, even though the muscles can be the same, the function of those muscles are different. If a man has pelvic pain, it can be similar to women in terms of that there's pain during orgasm. But with a man, if they have pain, they may have difficulty achieving an erection. Versus a woman, they may have difficulty even allowing any penetration. So it's more of the function that is different. And because, again, not being able to have an erection is something that can be seen, whereas not being able to accept penetration because of pain, again, it's not easily seen. And the woman may have some, because they want to have that intimate relationship with their partner, they may just suffer through that pain. Whereas a man will have a harder time if they're having a difficulty with an erection. Given that's although they can have pain in the same area, the function ends up being different.
So, in your experience, what is something that suffering partners does not typically realize about what the other is dealing with, and vice versa? What's your advice on that?
Pain causes a significant avoidance response. This is a very natural, organic response to pain. Unfortunately, that avoidance response can be perceived as a relationship issue. As a result, you may not realize that it's pain that's actually causing that distance between the two people. And instead, they may consider it more of a relationship issue.
Thank you. I know you guys have questions, but if you will just hold them till the end of the night, write them down. You have pads of paper, because I'm sure you have many more questions. Thank you so much. Dr. Somi Javaid, we're thrilled to have you here on the important topic of sexual health and gender disparity. What are the most common sexual health complaints that you see in women?
Hello, everybody. Thank you for coming. Here's a round for Patty, Sexual Health Matters. I'm a firm believer it is time to advocate, empower, and educate. Okay, so now's the time. Less than 30% of OBGYNs, think about it, we deal with genitalia. My husband's not a GYN. He's like, you deal with this much of the body, like how complicated it can be. I didn't get any training in residency or all my years of medical school. I went to 12 years of school on sexual health. And it was pretty amazing to me that We're not trained nationally, and so you need to advocate for yourself and find doctors who will listen to you. Because with sexual health with women, and we can get into men, it's different. It's not a physical, visible problem you can always see. First one's libido. Why do I have no sex drive? And you guys, I see 18-year-olds and I see 86-year-olds. And when I see an 86-year-old, I'm like, you go, girl. If that's my problem when I'm 86, then, that's great. The second one is arousal. So the difference between libido and arousal, libido is the intent or the desire to want to have sex or be intimate with my partner. Arousal is once things are going, am I getting lubricated? Am I responding? And some of my patients say, no, I feel dead. Okay, so we have arousal. The third one is pain. And there are a multitude, Kathleen talked about them, of where patients can have pain. It can be external. And externally, guys, that's not your vagina. That's your vulva or your labia. In the canal, your vagina, or up in your belly. And there can be a multitude of different reasons. Tumors, endometriosis, pelvic floor dysfunction. There are vaginismus, which is the inability to have intercourse. I mean, I saw a couple, they flew out from Seattle. 8 years they were married, and they never had intercourse because her vaginal muscles could not relax enough to have sex. And the fourth one, that it's not a dirty word, orgasm. So I have a ton of women who've come to me and have never had orgasm. Less than 30% of women can have orgasm from traditional intercourse. People are always surprised to hear that factoid. So those are the four major reasons women come to me.
Thank you. What are the available treatment options for women with sexual dysfunction?
So I heard when the first sexual health medication went up for approval in 2015, one of the FDA panelists said, we don't need a bunch of nymphomaniac women running around. I think there's over 20, right? 26 male medications for sexual dysfunction. We have one really that's for low libido. It was approved in 2015. It's called Addyi, the pink pill. Everyone compares it, they call it the female Viagra. That's kind of a misnomer because unlike Viagra, we don't take it on demand. It's a medication that has to be taken every night. What you all need to know and get angry about is in this country, not in Canada, there's a black box warning on this medication. So on a daily basis, I have women who've never even heard of this medication. There were 2,400 women that were studied for this drug. 60% were social drinkers. 0.2% had any problems with dizziness. They then took 25 couples. They gave them a half bottle to a bottle of wine. Okay, we all drank tonight, or most of us did, in 10 minutes. And then you took the medication and you had to have coitus or sex. Well, nearly 60% were passing out. Duh. So in Canada, they don't have a black box warning, but here they do. So that's been a limitation. Women don't have access to that medication because I've had so many come to me who their doctors won't write for it because they don't want to deal with the black box warning. They're like, oh, nope, don't want to do it. Because you have to have a separate license to write the sexual health medication. And then there's 3 that they're not really sexual health medications, but they're for sexual pain. One is an oral medication. It's called Osphena, and there's a new vaginal medication that's got great promise that also helps with orgasm and desire. And then there is Premarin, which was derived from pregnant mare urine. Think about it, Premarin, that's been around since the 1960s. So my frustration is the FDA hasn't done much since 1960. Time to get mad. Time to do something about it, ladies.
Aren't you glad you're here tonight? In your professional opinion, is there a gender disparity with treatment options available that are FDA approved?
Yeah, so I just touched upon that. Men also, aside from the medications, it's over 20 to 2 or 3 medications for women. It's other things. Men have penile implants covered. There's shots for them. There are a multitude of gels and patches and things that are covered for men. Women, there are, I think vibrators should be covered. I think there's a clitoral pump that can help with arousal. I think that should be covered. There are medications that help. There are devices that help. There is pelvic floor treatment that helps that's not always covered by insurance, and it's extraordinarily frustrating. Patty, I had a patient who came in, and it would have driven you to madness. They're sitting in there, and she's 65, and he was in his 70s. He had his blue pill, and they were upset because he wasn't having enough sex, and it was causing a problem in their marriage, and she really wanted to be there, and she wanted Addie, the pink pill. And I wrote it for her. And it's not, so when a medication is contraindicated, it means you cannot prescribe it for someone. It's just been studied in a different subset of women. And so the pharmacist refused to fill it, and then the insurance company wouldn't cover it. And so she said to me, she's like, am I too old to be having sex with my husband? And I said, no, honey, but that's the message that your insurance company is giving you. So, I mean, that is the disparity, Patty, that we're facing today, and it's maddening.
Girls, we need to make change. Thank you. Thank you.
You're welcome.
You're right. Give her a round. Dr. Courtney, we are so happy that you're here to offer insight on these important topics. Let's start here. Why is orgasm so different between men and women?
That's a little bit of a trick question
I
because
know.
the physiology, the physiology of an orgasm between a man and a woman are actually very similar. The same parts of your brain light up when you have an orgasm. The same endorphins and hormones are released when both men and women have an orgasm. The same physiologic response happens. You get these contractions of your deep pelvic muscles. So the physiology of an orgasm is actually the same between a man and a woman, but the getting there is very different between men and women. And actually, most of the literature on the differences in orgasm are in psychology journals as opposed to medical journals, because there's not a lot of medical differences between an orgasm itself. Like there are differences between getting there. For men, you stimulate the penis. It takes anywhere from 7 to 15 minutes for a man to orgasm. It's accompanied by an ejaculation. Women sometimes have an ejaculation, sometimes don't. Women can have a longer orgasm than men in terms of duration. Women can have multiple orgasms. Men can have multiple orgasms too, but there's a refractory period that they just can't get over. And some of the medications we have, like Viagra, can shorten your refractory period, but everyone's going to have a refractory period for men. For women, you can stimulate many different parts to get an orgasm. Breasts, clitoris, penetration, the G-spot, all can get, you can get an orgasm from all that. But the physiology of it is the same once you get there.
All right. Well, let me just tell you, earlier I was handed some questions from the audience that they wanted me to ask. And so, are you all right with this?
Sure.
Okay. It says, I am interested in having intercourse with my partner, but it seems like I get a bladder infection every time we're intimate. Am I doing something wrong? Is he giving me an infection? Now you know why this person didn't want to stand up. I don't know. This is a safe environment. What can we do to prevent this?
Okay, the first thing to know is that you aren't doing anything wrong, and there's nothing wrong with you, and you are not dirty. Like, I have so many women coming into my office who are so concerned that they're dirty, they're doing something wrong, they deserve these UTIs somehow. Some women are more susceptible to them than others. It's just, that's how you're born. Nothing you can do wrong to deserve these. I have so many women who try and clean themselves again and again and again. They get obsessed. They're like wiping constantly. I'm very clean. I wipe the right way. You're not doing anything wrong. The reason women get UTIs after intercourse is the bacteria gets pushed into the urethra. We have a short urethra. It's about 4 centimeters long versus men's urethra, which can vary in length, but women generally have about a 4 centimeter urethra. It's a very short distance for bacteria to climb. So the action of penetration pushes the bacteria up. So one of the things we always say is, oh, go pee after intercourse. That's a good way to flush stuff out. Spermaticides actually increase your risk of infection for sure. So if you're using condoms or lubricants with spermaticide, avoid that. Stay well hydrated. Dehydration can lead to urinary tract infections. You're just not flushing things out. You're drying out your bladder, your vagina. You're less healthy when you're dehydrated, so stay well hydrated. If your partner is uncircumcised and hasn't been cleaning under the foreskin, I would recommend doing that because bacteria can live under the foreskin. And that's the one time that I would say, well, maybe he's giving this problem to you. But most of the time, it's not his bacteria getting transferred. It's the bacteria you have in your vagina just crawling its way on up. You also have to remember, our anus is really close to all this stuff. So the bacteria from our GI tract can get right into our bladder very easily, and the most common cause of urinary tract infections are things like E. coli, which live in our body normally. So pee after intercourse. Don't use douches, that just irritates the vagina. Don't worry about using harsh soaps. Like a lot of women start using these soaps that are special for the vagina. Your vagina is really good at cleaning itself out. You don't need anything like that. Water is best, but if you really think you need some kind of soap, just external on the vagina, vaginal irritation can cause urinary tract infections. So, stay well lubricated.
You can tell I'm the gynecologist because I blame it on the man. I say, bad aim, bad aim, sister. But honestly, the doctor's right. It's a lot of bacteria that live on our skin that actually protect us. The only thing I would add is patients who are menopausal, who aren't on any type of hormone therapy, our skin really starts to thin. And our perineum and near our urethra. And if we're on some topical hormone or systemic, our skin is our barrier to infection. And so if we can thicken that skin, we can decrease the incidence of having a urinary tract infection, and then always voiding or urinating after intercourse helps. Now, if you have 6 or more infections in a year and it just keeps happening, then your gynecologist will put you on a antibiotic that you can take with intercourse. So that's another option that you can have. So that's the only thing I have to add.
Yeah, I do prophylaxis after intercourse for women who keep getting them. Come see us.
Yeah.
We're happy to help you.
Yeah, we'll help you.
Prophylaxis after intercourse. Some people, I put on a cranberry pill for daily, like a Allura. You have to have 36 milligrams of the proanthocyanins, which is like the ingredient that actually prevents UTIs. 36 is a magic number. You have to have 36 in there, otherwise it's a waste of your money. D-mannose can help prevent E. coli, urinary tract infections. And then I put a lot of women on estrase cream. I stopped using Premarin when I found out it was from horse urine, but there's nothing wrong with that. I just... Estrase.
Okay, here's your next one. Our sex life has diminished recently as my husband has been having issues keeping an erection. He tried a pill once, but nothing happened. And we haven't tried anything else since. I miss our intimacy. Are there any other options that we can try?
That's for you.
There are so many options. The first thing to remember is that not all intimacy needs to end with a penis and a vagina. Like, there are lots of other ways to be intimate. And so from that perspective, I try not, when I'm with couples, I try not to focus on, hey, let's get his penis hard. It's like, why don't we have conversations about what we want in this relationship? But in terms of how to help men with their sex life, you're right. Congress is all old white men. They like for other men to have erections. So we have 4 erectile dysfunction drugs on the market: Viagra, Levitra, Cialis, and Stendra. A lot of people think I'm going to take a pill and my penis is magically going to spring up hard. It's not how it works. These medications provide the right chemistry in the muscles, like the erectile muscles, that when you're stimulated, you're more likely to get an erection. But if you take the pill and you think, oh, nothing's happening, well, you got to think some sexy thoughts about stuff, do some simulation to actually get the erection. So Viagra is the most common, but it's also the most finicky. You have to take it on an empty stomach. It takes about an hour to work. If you take it on a full stomach with alcohol, you're not going to get a lot of action out of it. If you don't do any stimulation, you're not going to get a lot out of it. If the pills fail, there are vacuum erection devices, the penis pump. There are anywhere from medical grades to the ones you get at the Hustler Club. I think all of them are great.
No, we don't get them there.
No, we get them from here. No,
Hey, she's new to Cincinnati. Give her
I
a
am
break.
new to Cincinnati.
Okay, Pure Romance.
We get them at Pure Romance. They are great, but all of the penis pumps will work about the same unless you're paying like $10 for them. Don't get that one. If that doesn't work, you have other things like Muse, which is a urethral suppository, or injections into the penis. Lots of options.
And from the physical therapy standpoint, weak pelvic floor muscles don't allow maintenance of an erection. It's very important for the pelvic floor muscles to be able to maintain enough tension to keep the fluid in the penis. So doing pelvic floor exercises has been shown to improve erectile dysfunction. So that's another option.
I think the biggest barrier, though, is my patients will share with me, is they'll talk about it, is actually getting their partner to go in. You know, they don't want to make the appointment, they're too embarrassed, they're scared. So you need to go to someone who's obviously very comfortable discussing it, right? And it's not a big thing. And I think that's the biggest barrier for men, because there are so many more options for them that are FDA approved. They put their barriers on themselves by just embarrassment or fear, or, you know, just not wanting to go in.
Yeah, you're absolutely right.
Well, here's my last question for you. This is a good one. Okay.
I'm scared.
Can you really, let me start over. Can you really break a penis? And if so, how does that happen?
Yes, you absolutely can break a penis. There is not a bone in there. So there was an episode of New Girl where Schmitty or something broke his penis and he got a cast on it. That's not what we do.
That's not the treatment.
But the penis is actually very soft and pliable when it's not firm, and then when it's erect, it's engorged with blood, and you have these things called tunica, which is this, like the gritty part of a steak. It's like that fibrous part. Big, juicy penis steak, yes. But it's that hard part. And so when you break a penis, you bend that hard sheath until it breaks. And so you get a snap in that fibrous sheath. You usually have a popping sound. There is an immediate loss of an erection. And the penis swells up and bruises, and it's actually called the eggplant sign because it literally looks like an eggplant. Now, how do you break a penis? It's not easy to do. It's more common in people who are having really vigorous or acrobatic intercourse. So the positions to be careful of are doggy style or reverse cowgirl, where the female is on top and flipped backwards, because the penis can hit that perineum or that pubic bone and it just bends it real hard. So yes, you don't get a cast, you do get surgery though. So don't ignore it if that happens. Like, make your partner, or if you're a guy, go to the ER, because you get surgery. If you don't fix it, you can have long-term problems with erections or curvature.
So when I did my preceptorship out in California with Dr. Owen Goldstein, I saw a man who flew down there from Canada, and it looked like Gonzo's nose, yes. So, and Dr. Goldstein was so excited to show it to me, and I was like, I really, okay. But he gave him an injection, almost like, is it TPA, to break up it breaks up the scar tissue?
That was probably a while ago.
Yeah.
Right. So we used to use a calcium channel inhibitor, starts with a V. I forget. It's not. It was off label. What we use now, it's called Xiaflex, and it's a collagenase. Collagen is like when you form a scar, that smooth stuff. So it's a collagenase, and it breaks down the scarring, so you stretch it out, basically.
Try to straighten it out.
So it's called Xiaflex. Yeah.
Okay.
I'm gonna straighten it out.
I can
But
see
get
the
surgery
consultants
instead.
tomorrow sharing this at their shows. Thank you so much. Often couples need someone to help them open the conversation about sex, and sometimes there's stigma attached with seeing a sex therapist. Laura Pressley, thank you for being here. Here's your first question. Because of the stigma, can you explain what is a sex therapist? What do you do?
Yes. There are so many different things we can do, but I think the first piece is figuring out where the stigma comes from. It is what you were saying, where we feel like sex is dirty. So we feel like, well, I don't want to go to a professional and we're going to talk about, they're going to get in all my business, they're going to get all into my life, and I'm not supposed to talk about this. Depending on your upbringing, you might not have been able to talk about this at the table. And so there's some shame around this. And so there's some stigma around who can I talk to, who's going to understand, and is this something that's really happening? Is this really a unique enough problem that I should go to somebody professionally? So some of the things that we do a variety of things. Quite often we see couples when there's a difference in just different levels of desire. And so we help to open the communication and examine how are things when they were good, and how can we get to a space of conversation and communication about what our desires are, and how can we feel comfortable exploring different things with our partner to feel wanted and feel desired and to feel sexy. Other things that we do is we talk to people who are coming out of a relationship where they may have had negative messages about their body or who they were expressed to them, or maybe they've grown up with certain negative messages about their body. And so we see individuals often who are just thinking, hey, I want to date and I don't know, I've never felt sexy before. How can I even begin to think about feeling desirable when I don't see myself in the mirror that way? There's quite a few folks that we see for things like pain, of course, and how to deal with some of the feelings of shame or inadequacy when folks feel like they're not able to engage in certain sexual acts, or they feel that they're supposed to. Other things that we also work with, and other reasons to see a sex therapist, is there may be trauma in either partner's past, and there may be a space of assault or if something traumatic had happened in childhood, and trying to figure out and establish a new identity within that, where you want to create something different based on maybe something that had happened. And so working through that either on your own or with a partner can be really helpful, because then they can support you if you go together. And another thing that we also see is infidelity and recovering from infidelity, and some of that work, and working with either couples or individuals who are dealing with that. And so, yeah, there's a variety of reasons.
Well, my question is, what's the number one reason?
Yes, the number one reason that we see in the practice is really just the differing in desire. And so where one partner is like, I would love it like 8 times a week, 5 times a day, and another partner, and often it's that gender gap where traditionally women, we take on the roles of mother, of caretaker, busy with careers. There's so many demands placed on us, and often we're the ones that typically have lower desire than traditionally men. And so within that space, there's just a difference, and that comes with shame of women who feel, often we see, at least in the practice, where women are like, hey, my husband wants this and I don't. What do we do here? Open up the communication to figure out where are things, because the same things don't always work. I think for folks that have been together for 10, 20, 30 years, just walking in the room doesn't always do it. It might have worked at the beginning.
It's probably why I'm single. joking.
yeah.
Okay, here's my final question
Absolutely.
for you tonight. Do you have to be in a relationship to see a sex therapist?
We get that question a lot, and you absolutely do not need to be in a relationship to see a sex therapist. Some of the issues I was mentioning before of people may have had different pasts that they want to work through and process, or wanting to feel sexy on their own. And I think if you are able to learn how to feel sexy, learn what turns you on, what makes you feel good, experiment with some great Pure Romance products. There's so much space to grow and lean into that identity, and some folks, they just want a place to process their identity, and so before they get into a partnership. And so, yeah, encouraging the space for folks to explore that. Some work we do with couples where individuals see different folks and then they come together, but individuals, couples, young or older, yeah.
Well, I'm going to tell you, we could give her a big round. I could ask questions all night, but that's not what this is about. This is about a safe platform where we can open up tonight and ask. You've got 4 amazing doctors sitting up here, therapists sitting up here to ask questions. So who would like to get tonight's first question started? Okay, we're going to bring a mic to you.
I was just wondering, what causes that pelvic pain?
Asking me?
Yes, ma'am, I'm sorry.
Well, from a physical therapy aspect, we are looking at the physical causes, not necessarily the medical causes. In our perspective, it's the pelvic floor muscles or the lower back or the hips can cause pain in the pelvis. When you come to a physical therapist, we will take a look at all the muscles of your back, your abdominals, your hips, and your pelvic floor. And we can ascertain if those are the areas that are causing the pain. This area people are very unsure that it's when they come to us, they don't know what we're going to do or how we're going to help them. People, when they go to a physical therapist, they're thinking about, oh, I'm going to be in this big gym where, lots of people are going to be doing exercises and, I don't want anybody to know about this. But no, we have private rooms. We, make sure that your modesty is always in check. But we go through a full physical examination, just like as if you were going to a therapist to find out why your knee is bothering you. It's no different. We would take you through, we would check your flexibility, we'd check your strength, we'd see whether or not you have areas of trigger points where you press on it and there's severe pain that causes the pain that you're experiencing. So from a physical therapy perspective, it's the physical part, just no different than like a knee or a shoulder.
From a gynecology standpoint, it's looking at the skin, making sure it's not too thin. It's hormonal. It's neurologic. Sometimes there's that condition I told you about where the vaginal muscles just contract up. Endometriosis, which is a chronic GYN condition, ovarian cysts, fibroids, tumors. So there's so many things because it depends on where the sexual pain is. Is it in the vagina? Is it outside in the labia? Is it right at the opening, which is called the introitus? Or is it in the belly? And I will tell you, women come in and I even bring them a model because we don't know our own parts. And they're like, well, my vagina hurts. I'm like, well, that's not your vagina, but just show me, point to where it hurts. So it just depends. It could be a multitude of conditions. And if I can't find the reason, we do an ultrasound, we do an exam. Sometimes it's a tear. Sometimes it's an STD, gonorrhea, chlamydia, undiagnosed herpes. And then I send them to the therapist to deal with how they got it. But, so we look at all those reasons. And then if we can't figure it out, then, pelvic floor or physical therapy helps us out.
Oh yeah, I just had a quick question for Dr. Javaid. Are you currently aware of how we are combating the gender disparity with the FDA right now? Is there anything happening?
Yeah, as much to the dismay of my staff, I'm traveling the next 6 out of 8 weeks. So I'm fighting the good fight. I sit on FDA panels. I am involved in advisory boards. I am myself in my office am doing some research. The Patty Brisben Foundation has given away over $4 million. The FDA is asking for more research, more research, more research, and that's really what needs to be done. So it's there's national organizations now, the Sexual Medicine Society and ISHWISH. So there are doctors like me nationally that are trained now in sexual health and are actually doing research because that's what's going to give us the data. Because without that, new medications are not going to come to fruition. I will tell you there's something super exciting. A new medication was given to the FDA. We're crossing our fingers for March of 2019. It's truly going to be like a female Viagra on demand, meaning you don't have to, because the pink pill I told you about, you have to take every night whether or not you're having sex. And then it's got the sexy black box warning right now. This one is on demand. So we'll see what the FDA says because the pink pill was rejected twice. So we'll see what happens. But we have to get more involved too. For people who are not in medicine, write to your senators, get involved. There was a petition a few years ago. Did anyone even see it? Even the score? It was on Facebook, it was on the internet about demanding more research to be done for women's sexual health. And I once had someone say to me in a meeting, well, she's not going to die from it. It's not a real disorder. And I'm like, yeah, but she may lose her marriage over it, or her life as she knows it, or it might tear away from her self-esteem. So don't say it's not a real disorder. So in education, right?
Absolutely.
Yes.
So you talked about advocating and education. A lot of times we have to pull information out from our clients in the bedrooms to talk about what they're interested in. Have they ever thought about a bedroom necessity before, right? So how forthcoming are they coming to their gynecologist talking about their sexual issues? Do you kind of have to pull that information out, or is it still a stigma to still talk to your doctor? And I know as consultants, we will encourage that to talk to their doctors and talk to their, physicians and us for the things and items that they need.
Our patients call our office the rabbit hole. Once you go in there, you don't want to come out. Our door says sexual medicine, so I think you kind of know what you're getting into. I help, though, other physicians kind of tease this information out because it is a very delicate issue. We have it all, you fill out all those forms when you go to the doctor. So we've made it a part of our electronic medical record. So even if you're just coming in for your pap smear, you are answering about 20 questions about your sexual health. And that way someone doesn't feel isolated or she's picking on me or she thought something was wrong with me. And then I have that information. And then we even ask a very specific question. Are you wanting to discuss options today? And you'd be surprised how many women, because they're meeting us. Yeah. It's there, they want me to know, but they're not ready yet, right? And so we respect that in our office, and we give them the opportunity to get to know us. We tell them about what's out there, and then they come to us when they're ready.
That's good. The other question is, the other question that's usually on there is, are you sexually active? What does that usually mean? You're married or you're not? I mean, that's just a very general question, and for some women, they don't know how to answer that. They don't know how to bring that forth. So I love that idea of putting all that information on there. Right. I did have another question. So I work for a pharmacy, and I seen a prescription come through for testosterone. for I think 1% applied to our clitoris. So we have enhancement creams. So how different is that from some of our enhancement creams? Is that a stronger amount, and do women come forth and are willing to get those filled at the pharmacy?
So testosterone and enhancement creams are different. First of all, testosterone is not FDA approved in a cream form, even though it's made in your ovaries. Did you hear me? Not approved, but it's in our ovaries. So it is approved in an oral formulation. I don't like it. Gives women too much acne and hair growth. So what it does for women, it does help. We have a bunch of receptors on our external genitalia. That's what estrase and the other things that we were talking about. That's all estrogen. Nobody wants to talk about, and this has been proven out at the San Diego Institute of Sexual Medicine, we have testosterone receptors too on our external genitalia. And there's proof that it helps us with orgasm, can help with pain, and increases sensitivity. It just feels better. Like the drug Interosa I was talking about, it's DHEA, which is a natural form of testosterone. It breaks down into estrogen and testosterone. And they have FSFI data. So that's how you measure sexual health drugs, FSFI, Female Sexual Function Index. They have data on orgasm, arousal, and libido, but they haven't presented it to the FDA yet because their concern is the FDA is going to say no way. So they went for the easy indication, which is dyspareunia, which is pain. But there were already a ton of other drugs out there. I know all this information because I speak for them. And I go around the country telling people about this. This is not something they tell everybody. And now you guys know, so you can ask for this medication and say, hey, I want to try this Interosa. But that's why, so I write a lot of testosterone. A lot of traditional GYNs will not. So, because we were not taught that in medical school.
One of the things in urology that we're really looking at is selective androgen receptor modulators, SARMs, for pelvic floor and incontinence issues, because we have a ton of muscles that atrophy, and testosterone works on androgen receptors, and it's helping bulk up the pelvic muscles for incontinence and things like that, but also pain and libido and all those other things. So it's in the pipelines in the urology world as well.
That's awesome.
Hello. So we know that different medications can cause a decline in sex drive. So mood-altering drugs, birth control, that's the number one thing that I hear from my clients as a pure romance consultant is, I went on this birth control and now I have no sex drive. So are there some safe alternatives that I could recommend that my clients talk to their doctors about?
So I try to get all my patients, if they are having low libido, because I do prescribe oral contraceptives. It's almost counterintuitive because I also do sexual health. It's great for pelvic pain. It's great for endometriosis. It's great for heavy menses. But some women are more susceptible, and it really binds up all of our testosterone. It upregulates something called the sex hormone binding globulin, which I lovingly call the Pac-Man to our testosterone. And so, women are like, why do we have to pick? Great skin or great sex? I'm like, I know, I'm sorry. I generally, right? Which one? And with Addie, it's like wine or sex. So I typically will switch them over to an IUD, which can still have some of that effect because it does stop ovulation, but it's not nearly as severe as the oral contraceptives. And they'll tell you, oh, switch to a lower pill. It does the same thing. So IUDs, or if they're done having babies, I encourage them to go see their urologist to go get a vasectomy. Because the childbearing's been done. I feel like we've paid our dues and it's time for the guy. And if not, abstinence is great until he relents.
See the men in here going, what did I come to?
I wanted to add a little bit just to that. When I think about the birth control piece, I think we don't have conversation. So some of what we do is just some education with couples to say, you don't have to feel like the guilt and shame if you're taking longer, if you're taking, instead of used to take, 20 minutes to get aroused or to get lubrication, it may take 35, 40, it may take longer time. So how to plan for that, how to include that so it doesn't feel like, oh, I'm broken because I don't want to get pregnant. And so now there's so.
Okay,
so I know this might sound a little crazy. I didn't know that a sex therapist was a thing until tonight. Crazy, I know. So as a consultant, for consultants, and I know that, and this is the sad part of it, is a lot of the times we will have ladies, because we build relationships, that will open up about sexual abuse.
Yes.
Is sex therapy something that they may want to look at?
Yeah, absolutely. And so we have different, so there's different folks in the practice who really have a background and a really, that's their specialty, is in trauma or in early age trauma. So traumas as children or kind of under the age of like 25. And so it's so common. And so that can absolutely be a place to talk about because it may, it has an impact in your own sexual identity or in the folks that you're working with. It has an impact there, but also it may manifest in the relationship quite a bit. Some couples will say like, well, I just come behind and give them a hug, and the partner, it gets triggered. And so they're thinking like, oh my gosh, this fight or flight, and it really does, I think, either individual counseling or couples counseling so needed to help have communication, help process some of that trauma, and also to create some awareness of how can I support my partner? I didn't realize what she'd gone through or what she'd experienced. How can I support her when I don't want to ever ask about what happened? How can we do this? So thank you. I'm glad you learned about that today. That's exciting.
There's one here, and then we have another question right here.
I have a client who has MS, and she actually lost the sensation in her vagina, so when she has sex with her husband, she can't feel anything. Is there anything out there that she can get to get that sensation back?
That is a tough one. I don't know of anything other than PRP, which is platelet-rich plasma, to try to regrow some stem cells and some tissue in there. They're currently using it. I don't know if you guys have seen it, the O-shot. Initial studies in women have not been that promising. In men, it's been better. Yeah, you're like, yeah. I don't do PRP, but I think that would be the future. There is a great doctor out. If you contact me, he does 10-minute free phone consultations for these really tough cases, and he's actually doing some studies in women with PRP to try to regrow tissue. So she might be a candidate for something like that if she could fly out to San Diego. But it would be more of a research. There's no mainstream therapy that I know of that's available.
The other thing, sometimes for my spinal cord patients who don't have sensation, we do vibration. And so a really fast vibrator sometimes can not necessarily, they don't necessarily feel it, but the brain gets stimulated in that right way, and they will orgasm. So that's, I don't know enough about MS and how to do this to recommend it, but for our spinal injury patients, that's one way that we can get them some sensation.
Yeah. I would also, just to other things, well, at least in the therapy worlds, we don't necessarily know the interventions, but there could be a lot of grief work for her and her partner to sort of, I don't know when she'd find out about her diagnosis, but if they'd had a previous sex history or an intimacy history that they liked, they could be really feeling anger or frustration, or feel like, I don't know if I want to still be here if I can't receive pleasure, or if I can't get it. Is this fair for me to stay if my partner could go elsewhere? And so it might be really helpful to look at doing some couples work to sort of find out what could be kind of a new normal. What might it look like to stimulate different erogenous zones? What other things feel good? How can both find a new way to communicate what they might both feel is desirable and fun and sexy, but it just is going to might look different than what they've done before. So doing some work to explore that.
And if they miss that intimacy of being, chest to chest or on top of each other, I had this for an older couple, and he just missed that. And so actually one of the Pure Romance products, I don't know the name of it, but basically We call it a handheld vagina. She would put it between her thighs, and he would insert himself in there. Because I know we talked about that it doesn't always end with penetration, but that was important to him, and he wanted that physical contact with her, and he missed it. So that was one way we introduced intimacy for them, if it can't be where it was before.
So you know what she's talking about. Okay. Masturbate. Yeah. All right.
Hi, my question is for Laura. How do I communicate with my partner that what he thinks is amazing and incredible is not necessarily that amazing and that incredible, but to do it in a way that does not hurt his ego or cause him to be upset?
Yes, she got like a high five. Somebody's like, "You are brave." Yes. I think there's lots of different ways to go about this. I will say, just like, first off, one of the things that I find helpful is that sometimes masculine ego can be a little bit fragile for me. And so I find that encouragement has worked really well. So in some spaces, I might encourage the male partner, if he feels like he's maybe had the same moves since high school. Just some education of like, hey, I love when you touch here, or it's really great when you do this here, or oh, I stopped and I noticed that. Often as women, we sometimes get socialized to be really quiet and passive and just sort of make up a grocery list and and not to interact. But that communication of like yes, even just the short word of yes here, can be so helpful in trying to encourage and say like, wow, you did this move here. I really would love it if you continued that. It's definitely, I think, a conversation for like, not before you're in the bedroom of like, all that foreplay, you're doing like 3 minutes and I need 30. It might be hard to do that later, but it could be something on another time when you're not feeling the sexual arousal feelings to actually say, hey, let's have a conversation about this. There are some other resources too that I encourage. There's a few different online resources. One's thinking of like OMG Yes, but it's a resource that helps. I give to some couples. It's online, virtual, where they examined 1,000 women and looked at what touch and what type of pleasure could be sexy and arousing. And so for some, I've actually set like one partner up with their iPad to just figure out some new techniques that each person could be excited about, where he was like, I learned a whole bunch of new tricks, I want to try this out. And that was, like, okay, that was good. Like, I want to go try that out. So, yeah. Thanks.
Hi, so I'm being a little open today, but I actually suffered a uterine prolapse. And at that time, I did not even know what a uterine prolapse was. And my uterine prolapse was so sudden, and my whole muscle just ripped in half. I had to have an emergency hysterectomy and have all that, taken out. And I did suffer some bladder damage due to it. And so you were speaking about the incontinence and the pubic floor and everything, and I was just wondering, is there going to be anything in the end that's going to help with my incontinence? And also, is that probably the major, I don't recall before having the uterine prolapse crawling away from my husband, and now there are times where I find myself in so much pain that I'm trying to crawl away. And so and really, they just did the surgery and sent me on my way. And that was basically all I was told and given. I was told, everything's fine now, you've had surgery, and I left.
Yeah, that's an unfortunate thing. A surgery like that is a pretty major surgery. Someone that had surgery on their knee that was that extensive would expect that they would be referred for physical therapy. to have a uterine prolapse, not only are your muscles damaged, but the ligaments that were holding that uterus up were also damaged too. And then, of course, anytime you have surgery, you also end up with some scar tissue. So no different than having a major knee surgery. You've got to get all that stuff working normally again. Some of your pain could be from the scar tissue. There are, physical therapy that you can do to loosen up that scar tissue and make it elastic again. Your muscles are probably also in a protective mode still. Even after injury is gone, your pelvic floor muscles can remain in that tense position. And in the yeah. Well, when we are aroused, our pelvic floor muscles should relax, and they actually move down and away from the inside of our body. And when they're in a tense position, they're kind of like up like this, so it shortens that canal. So if you had surgery and that also may have shortened the canal, that indeed he is hitting something, and it can be painful. It could be a scar tissue that is more sensitive than it was before. And then these same pelvic floor muscles, if they're in a tense position, for them to control your bladder, they need to be able to change position. When the bladder starts to have an urgency, it's not where the pelvic floor muscles contract and they stay that way. What they do is it contracts, it inhibits that urgency, and then it goes back down to relaxation till there's another, sensation of, oh, I have to go. If your muscles are already up here, when the bladder starts sending you that signal, I've got to go, there's no place for that contraction. So the bladder gets no signal, and so you may leak that way. Go ahead.
There's data out of Europe that sex feels very different after a hysterectomy. So I want everyone to touch your nose, okay? That's what a cervix feels like, okay? And the cervix has 3 nerves that make sex feel really good. And when you lose your uterus and your cervix, touch your cheek. That's what vaginal tissue feels like. So you can see it's not as satisfying to either partner. I agree with the scar tissue. That's the difference with the way sex feels. And then I'm going to let you talk about the bladder.
In terms of incontinence, there's, number one, it's really common. So you are not the only one, probably in this room, that has incontinence. So you shouldn't feel embarrassed or alarmed about it. There are things that we can do. So you should not be embarrassed, and you should be very hopeful, because there's lots of options. There's 2 different types of incontinence. There's one where you cough or sneeze and a little bit leaks out. That's stress incontinence. And a lot of that is pelvic floor muscles and just a lack of support. Again, we have that short urethra. So if you lose some of the things that keep it tight, it doesn't have far to go. It's a short little distance. Another type of incontinence is urgency incontinence, where you have the urge and you can't hold it in because you're already going. There's medications for that, and there's other options. And for stress incontinence, I think pelvic floor therapy is great. And if pelvic floor therapy doesn't get you all the way where you need to be, there are surgeries from very small surgeries where we just bulk up the urethra to larger surgeries where we're pulling everything back into place and putting a sling in. So there's lots of options, and I think you should talk to someone if you want to. You don't have to, though.
So I think there's a portion of the population who understand how common sexually transmitted diseases are, and then there's another very large portion that do not understand that, and so obviously that creates a very negative stigma around sexually transmitted diseases. So my question is, how do you respond to a question on shame attached to sexually transmitted diseases, and after that, how do you communicate it during intimacy?
I was thinking about it. I agree. There is so much shame related to STDs, STIs, all of that, and we miss out. And so I think about women who have complications from not seeking out medical help or not seeking out their gynecologist to find out help and support, to have interventions if there are some. And so I think the second part of the question, and then I think I might get back to the first part, was communicating about that can be very challenging. I think some of the work that we could potentially do as individuals is working with a sex therapist to figure out how do we feel about it. If there's too much shame around this, where it feels like you're not able to share this piece and not able to express who you are with this potential new partner. So that can be a challenge of just feeling like I don't want to even date, or who would want me, and so feeling that shame before even pursuing somebody, or not feeling worthy on yourself. Depending on the conversation and depending on what the disease and what the space of, if that it's something like an oral, something that's like an oral herpes or something in that capacity where it might be visual or have flare-ups, there may be some things just of kissing where it may not be something where it's touching of genitalia at that point, but how to share that early just to reduce your exposure and your partner's exposure, depending on how early you want to introduce that. But I find for some couples, having some conversation in a non-sexual space, having coffee to tea to explore that after it's been a few dates, a few meetings, to see if there's some space there where you feel like you want to pursue it, or and if you want to share that vulnerable side about yourself.
We have couples come to the office because I think a lot of anger or isolation is just not knowing, and it's fear. So both partners will come in and they'll have their written questions, whether it's herpes or gonorrhea or chlamydia or HPV. And they come in with their questions and they ask about, how likely am I to get this? Are we just going to keep giving this back and forth? What can we do to stay healthy? And I think education is, really empowering for people. So a lot of our female patients will bring their partners in. And I think it's very helpful to both parties because the fear disappears and is replaced with education and answers.
I just recently have come into contact with a few women who have the Muslim background, and they had their glans clitoris, sorry to be vulgar, but it was cut off as young girls. And I'm curious to know, I heard you mention before about the vibration, for the brain stimulation and things. Can I recommend that? Do they get any feeling down there? Like even, for instance, maybe through anal sex, because the way 91% of women can orgasm through anal, can they feel that, or do they have no feeling whatsoever? Because I don't want to give the wrong information, to them and things like that, because this is kind of all news to me. I didn't realize it was so vulgar for them.
They actually need an exam because, well, first of all, I want to clarify, it's not all Muslim background, right? Like there are people from different countries, it's definitely higher in certain percentages. But it depends on how much of the tissue was removed. Like I delivered babies from women who the labia minora, so the small lips, the clitoris, the clitoral hood, everything was gone, or women who just had the clitoris removed and may have had a stump that you can actually stimulate. So they really, without an exam, I don't feel like you can tell them. You can do a Q-tip test, which is just a really archaic test we do in the office, and see if they have any response. And then I'm sure with pelvic floor, I don't know if you can do anything with that, but to see if they have any feeling left, and you could stimulate it with either a laser or testosterone or something. But they actually grade them. Yeah.
You should also remember that we were talking about earlier with orgasms, women can orgasm in a lot of different ways. So penetration, when they do have like genital mutilation, which is what it is, you don't take the whole clitoris out for one thing. You just take the hood, which is basically like the glans penis. So a lot of women will still have vaginal sensation. They'll still have the G-spot, which is just a little collection of nerves. So there's other ways to get pleasure. But definitely need an exam, and I don't know if I would recommend like certain sex toys over another. Yeah. Sure.
I have a girl on my team who met a woman who was born without a clitoris and did not know she was born without a clitoris until she was in an anatomy class. And at this point, she had already had a child and no one had pointed it out to her, which I don't know how you would point it out or have that conversation. I just wanted to put it out there because some of the doctors that she saw after that said, they did some sort of procedure. I don't know what it was, but they had never seen it before, that someone born with that, and they didn't know if that was because people aren't coming forward and saying it, or maybe they just don't know that they don't have a clitoris. So I didn't know if you'd ever heard of that before.
I've definitely seen congenital clitoral anomalies, and I've seen patients go upwards of, remember, we're in a big city. We have pure romance here. Like, I've seen women go to 7, 8, 9 gynecologists. You've got to remember that sometimes your internists or family practice, who they've done 3 subspecialties in 3 years, are trying to do them. And a lot of times, I mean, GYNs are guilty of just putting the speculum in and getting the pap smear done and running out of the room. So I've had that where I've had patients and I look at them and I'm like, there's something wrong here. You have a phimosis, or this is not developed correctly, or you have scar tissue and it needs to be released. So I can definitely see how it happens in an office where you see 50, 60 patients a day. It doesn't make it right, but no, I've definitely seen those anomalies. I've even now seen women with herniated discs who are presenting with anorgasmia, who they had tried everything, the O-shot and laser and the drugs, and nothing was working, and you come to find out that the clitoral nerve is compressed, and that's why they're not having orgasm. So they're doing some research out in California about that. So this down L5, S1, so.
I was just going to ask, I know we have really great resources through PBF and some like on our Pure Romance training and things, but are there any other resources, online books or anything that you all would recommend for us to get some good knowledge from as far as what to bring to parties or just to know for ourselves as women?
Yeah, I was going to say I've got a couple. Online, the one is OMG Yes. That's one that I use quite often. It's really informational. It has women of different sizes and ages and just helps explore their different ways of touch. And so it's just a really helpful resource. Come As You Are is another great book to describe just different sexual desire and arousal, and it really helps to break that down. The Guide to Getting It On is another really great one. It's really helpful with lots of different, it's diverse, so that's really helpful. And Lady Sparrow is a website that, for folks with vaginismus, it's another resource to help talk about for the couple to access and just have a community of folks who really understand what's going on. But I'm a big fan of other book resources, so I'll let others go. And
there's another campaign coming out. It's called the Right to Desire, and it's all focused on female sexual health. I just shot some informational videos, and there's some national experts involved in that, so that's going to be a great website once it's up. And I mean, I think I use Lady Sparrow as well. And then, ISHWISH, the International Society for the Study of Women's Sexual Health. They have a tab for providers, and they also have a tab for patients. And so if you want to read or you want to send your patient somewhere, that's also another great website with a lot of links to information.
For the physical therapy, there is a women's health section, and all it is Women's Health APTA. And there's a number of resources within that website for you.
So this question is for the physical therapist. If you have a background in dance, you just kind of unconsciously do Kegel exercises all day long. I mean, is that anything that helps anything? Does it strengthen the pelvic floor or anything, or is it just something you do?
Very good question. If your pelvic floor is mobile throughout that time, then it's excellent exercise. I have had dancers come to me that in order to be able to do the challenging activities that their dance requires, and they don't have sufficient core strength, they end up bracing their core and their pelvic floor, and that can be damaging to it. And that's when I usually will see them for pain, because they're in a constant tense position rather than a active movement strength position. For that, it's a matter of evaluating that, educating and helping that person gain the strength that they need to do those challenging activities. And most of the time, you're not even aware that you're doing it. You can be trained otherwise. The pelvic floor, because it's hidden, it's not as easy as showing somebody how to move because they can't tell what it's doing. And that's where biofeedback comes in. We can help someone actually understand, oh, I didn't realize my pelvic floor was staying in that tense position while I'm doing this. And when you see it, oh, look, if I do this, this is what happens. So that would be the thing I would look at. Are you actively using your pelvic floor and your core throughout the movement, or are you bracing and keeping it tense because you need to do that in order to accomplish that challenging activity?
But do Kegels help prevent further damage for your pelvic floor?
Yeah, and one thing I'd like to say about Kegels is that, that was the term that we used when it was first created. And it was strictly at that time as a strengthening tool. It was strictly for, weakened pelvic floor. Well, we've come a long ways. And so physical therapists will tend not to say Kegels. We'll say pelvic floor exercise. And because we're looking at the full function of the pelvic floor, we want it to relax the way it should. We want it to contract the way it should. We want it to respond to stimulus the way it should. And so we're not doing really Kegels anymore. We're doing pelvic floor exercise.
Okay, this is a little awkward. I have a 9-year-old daughter, and I'm so completely afraid of when she hits puberty and wants to start doing anything sexual oriented. How good of an idea is it to suggest masturbation to her and possibly supply her with a pure romance product?
How old?
Not at 9. I'm talking when it comes. I'm just saying I'm scared to death because she will be there sooner or later.
Then I'm going to tell you this.
Okay.
You guys can take a break. So I'm glad you asked, because that is going to be our next session that we'll be having in January. How is it that we talk to our children about sexual health? Yeah, so can we save it for those experts? Right. All right. So I'll give you a little bit more information, but right now I want to give these amazing, amazing therapists. And
thank you.
Yes, Thank you. Oh, this makes me want to cry. You guys were amazing, and I'm going to tell you what, my heart is full, and thank you for giving back to women's sexual health. I want to thank each and every one of you for coming out here tonight, and thank you for your continued willingness to learn and ask questions. And finally, I'm going to tell you what, I would like for my staff to come up front here, because I want to thank them, because without them, tonight would not have been possible. If we have any of our, which we do, any of the Patty Brisben Foundation board members in the room, please stand up, because they deserve a big round as well. I'm so proud of all of these people that are in my life, so thank you so much. By the way, you were provided with note cards when you checked in tonight. We encourage you to use any of these for outstanding questions that you may have. I want you to write them down, and I want you to leave them at the registration table. Why? Because our experts has said that they would volunteer to answer those questions, and we will be placing them up online in about a week. Thank you. Now, each one of you will also receive a post-event survey to help us better provide for our events. So we need more input on topics and where we're going to be moving for the future. I need you to get your phones out because we are going to give you the next date. It is going to be on Thursday, January 17th at the new Riff Distillery. We'll be exploring again the conversation on how do we speak to our youth about sexual wellness. So I have a feeling after speaking with some of the doctors from Children's Hospital that we will be probably taking it in segments from birth to 5, and then 5 to puberty, and puberty on. So this is and let me tell you something, listen carefully. I encourage you to call your friends. I encourage you to call your relatives, your neighbors, and I encourage you to encourage them to bring their significant others. This should not be a conversation that is just about women talking to their kids. Both partners, both male and female, should be held accountable for speaking to our children. Don't forget, tonight, Pure Romance has a free gift bag for attending, and I want to also announce the winner of our raffle. Did you dig deep in there? Okay, no, we got it. Okay.
That's what.
Emily Pan, you've got it. Yes. Thanks.
Wow.
I know you will put that to good use. And Emily's husband's with her tonight. Thank you, everyone who participated and supported the PBF, and thank you for supporting women's sexual health tonight. I need you to leave here tonight, and don't stop the conversation. You need to pay this forward. Talk about this event, about tonight and what you've learned. Again, I want to thank you and safe travels going home. The doctors are going to stay if anybody else has a few questions. Thank you again.